Okay, we are back for part two of our talk on hormone diagnosis, treatment, all things hormone related. We're back with Erin Sengel, who's a functional medicine nurse practitioner, and Ariella Bickell, who is a pelvic floor specialist physical therapist. So, welcome back, you two. So, last time we talked all things diagnosis. How might someone know when hormonal issues might be a problem, how to get tested, things like that. So let's focus a lot today on okay, someone now knows that they need some hormone treatment. What are their options? So, what are the main ways that a hormone imbalance could be treated, and how do each of you, because you have very different professions, how do each of you decide like the right starting point for someone in this situation?
If I'm suspecting it and they have these kinds of things, honestly, like Erin would be someone that I would go to because we want to find out more answers of like what's actually going on. And then based off of that kind of, I mean, ultimately I'm helping their symptoms. So like I will be treating their symptoms as I see fit in terms of with like the pelvic floor. There's a lot of different things that happen there, as well as musculoskeletal. But like they need to really know more information because from the hormone side, they also need to figure out what's going to help them. So yeah, that's kind of the first things first is I take a look at what I see, but I need to know information. So then I would send to Erin.
Yeah. So for treatment, how I usually start appointments is I kind of ask people what their big three are. So, like, if there's three symptoms that they're presenting with, and those are the most bothersome or the most troubling, that will help my detective work on where to start. Because what I think might be bothersome, they might not care about at all. And then usually symptoms tend to be derived from either progesterone or estrogen. And so if they are complaining of hot flashes or brain fog, something like that, well, then I know I'm going to start with estrogen. If they're talking about increase of like unwarranted acute anxiety, difficulty falling asleep, then or maybe like a change in heaviness of period, then I'm going to go down progesterone. Ultimately, if they have an intact uterus, they will have estrogen and progesterone on board as far as treatments go. But I start with the one that is causing the most troubling symptoms first. And then we flush that out. We tinker with that until we like where we are. And then we'll add on the other hormone. Like I said, if someone has an intact uterus, if they are on estrogen, they must be on progesterone. So both will come on board. If you are on progesterone, you don't necessarily need to be on estrogen, but most people want both. But so that's how I start treatment is based on their top three. And then that's what I start with first.
Got it. And you mentioned tinkering. I'm sure it's a process of figuring out what works for each individual person. How does that tinkering work? How do you decide how to change things as things go? How long might that process take to find the ideal amount? Talk us through that a little bit.
Um, Hopefully not too long, but obviously in this world of humans, there is a ton of variance. But I take into account their age and the severity of symptoms. If someone is new into the perimenopausal game, they are going to warrant a higher dose. They are used to higher levels of, let's call them free floating hormones than someone that's maybe postmenopausal. Well, I will start with them with a lower dose. The other thing too is mechanisms of delivery. So for instance, with estrogen, we have oral, we have topical in the forms of gel, spray, and patches. And then we also have a systemic vaginal ring. If someone has a history of like TIA or cardiac events or something like that, then oral's off the board for them and we go transdermal route. If someone has nothing in their medical history, then they're a candidate for any of the above. If there's someone that hates the idea of putting something on their skin, well, transdermal's off the board. And so I kind of go through that, and that's how I get to the best mechanism of delivery. And then also, like I said, I start with a dose that's kind of based on their life stage. And then we will up or down in order to get symptomatic relief. With progesterone, we don't have as many options. It's oral, and that's it. The progesterone molecule is too large to be absorbed through the skin. So it's oral. though we do have some combination patches with progestins. So on the progesterone route, it's more deciding between micronized progesterone, which is what we inherently make, versus a progestin, which is a synthetic form. There's nothing good or bad about synthetic, but they all have a different profile of who they speak to more. Some are better for what we call a bleeding profile, so someone that has a lot of bleeding. Some is better for those that might have headaches with it, other things like that. So that's how I go through the progesterone side is what their symptom is. The other thing too is I always ask like, hey, have you ever been on birth control before? And if they say yes, it's either a wonderful ride and they didn't know they're on it, or it's a really crappy ride. And so then that also helps me like kind of go through the weeds to be like, well, if they didn't like that, they didn't like that. And so that's how I eventually get to a decision.
Got it. So it sounds very individualized and lots of different paths that you
Yeah.
can go based on each person. Is that
Yeah.
okay?
Yeah. And so that's why I always tell people like when picking a provider, a lot of times, I mean, we are providers, we are humans. It is impossible for us to know everything. People kind of find their tried and true as a provider. So they might always do a patch and a pill, and that's it. And that's all they know. And that's all they're comfortable with dosing and prescribing. And that's fine, but it might not be the best combination for each and every patient. And so if you find a provider that only has one method and it doesn't work for you, then that's kind of a clue to find someone else. And going through that, or if they only give you birth control. Birth control is an option. It absolutely is an option during this transition. It's not the only option though. So those are kind of the two things that are sort of red flags, is like if they are only willing to put you on birth control, or they only have one method and they don't work through this sort of algorithm, then I would kind of lean towards going to someone else.
Yeah, no, I think it's super important to realize how variable it is, and do you have options? Because I think a lot of people now are scared of going on hormones because, the Women's Health Initiative, which was there to help us, but instead it made people scared, and it really dropped the amount of people that are using it. But there's so many different doses. There's so many different ways. If it's not working for you, try something else. Like, it's not a one size fits all. And there's a lot of options that are going to be safe for you. Like from like my point of view too, for like the pelvic floor, like degenerative urinary like function, a lot of people will benefit from topical estrogen, and they're like, I don't want estrogen, but like the amount even in the topical estrogen is so little, and it's so localized. So like it's good. Like there's just so many options. Like you do not have to go on hormones if you don't want to. Like that is also fine. But don't definitely look at different options, and don't be afraid, because there could be something out there that's a really good fit for you.
And to your point on vaginal estrogen, like you're saying, it's very localized. It does not have systemic effects. And even on that point with vaginal estrogen, we have creams, we have suppositories, and we have rings. So like a ring's set it and forget it, change it every 3 months. And so there's options there as well. If people are like, I am not putting cream in my vagina, well, put a ring in there, so there's options even there too, for things. And it is localized, and also, the Women's Health Initiative, that study was supposed to, help women. And it's crazy because they shut it down prematurely, and there's never been a PR campaign to undo like the wrong that came out of it, and the misinterpretation that came out of it. What came out of it, people thought about the increase in breast cancer. We have to talk like relative versus increase, like versus exact increase. And so it went from like 4 out of 1,000 women to 5 out of 1,000 women. So that's like a 25% increase. That sounds huge, but like in true numbers, that's not actually what happened. And then there's so many other flaws, and we can talk about that. But for those that are scared, or maybe they have a family history of breast cancer or things like that, those people are still being treated. In addition to estrogen, we have SERMs, selective estrogen reuptake modulators. And so it's kind of like a bespoke estrogen, in that you get the benefits of estrogen, but it doesn't speak to the estrogen receptors. So it's not feeding them. If you have maybe a estrogen dependent cancers in your family or something like that. So there's options for even people that grandma died of breast cancer, or, something like that. Also, if grandma died of breast cancer at 90, that's a lot different than grandma dying of breast cancer at 40. But these are all conversations to be had. I guess the big thing in this is that there's no like one way, and there's no hard and fast rules. And if that's kind of an attitude you're getting from your provider, then definitely seek someone else, because there's always an option.
So, Ariella, being a pelvic floor therapist, you don't just treat pelvic floor, you treat lots of different conditions. When one of your patients also goes and gets hormonal treatment, how have you seen it impact your ability to work with them, or how does it change your treatment approach, or just how does that then like fit together with what you're working on?
It really kind of help like their pain. Like if they're just like this hurts and then this pops up and then this thing, then this thing, then this thing, and then they start getting treatment, they're all of a sudden like, I feel fine. Like, we can really like hone in on like what is actually going on with the body. Like what are things that we really need to address from a physiological standpoint. And they're just like, it's just they feel stronger. They feel more motivated. They're probably more likely to adhere to their exercises. They're just in a better mood. And that could really affect again how they're doing in physical therapy, how they're doing in their own lives, and their pain in general. Of course, also it can help in terms of some of their symptoms for pelvic floor too, like with pain with sex and things like that, or UTIs. We of course, there's from a muscular standpoint, from a tissue saver, things like that. There's things still from that we need to work on as well. But sometimes when people find this roadblock and we're working on all these things and things just like aren't improving, that's when that other treatment that they're getting is really going to help get them unstuck, so to say.
And then conversely, Erin, when someone's, on hormonal treatment, how have you seen pelvic floor therapy kind of work alongside what you're doing?
Obviously, in that life stage, you have a lot of postpartum women, but also you have women that are going through that decline of estrogen. And if you've ever seen a picture of like an estrogen rich, like vaginal atmosphere versus an atrophic vaginal atmosphere that's been depleted of estrogen, you can see just the vascularity, the suppleness of tissue, things like that. So people that are on hormones, whether systemic or localized, and then having the pelvic floor physical therapy, to Ariel's point, you're enhancing those tissues and the functionality of those tissues to then, like, if you are going to pelvic floor physical therapy, the work you're putting in you're going to reap those benefits more so. And so whether it's stress incontinence, whether it's chronic UTIs, pain with penetration, things like that, those hormones are going to help treat some of those symptoms, alleviate some of those symptoms, and even prevent some of those symptoms. So we know UTIs into our senior years can be debilitating. And so keeping that at bay. The other thing too is to the point of prevention. I know, like, as soon as women become pregnant, it would be great if they were automatically paired with a pelvic floor physical therapist. It would be great as soon as we begin to enter mid-late 30s if we started on local vaginal estrogen, so that we don't wait till we're getting UTIs. We don't wait till we have pain with wiping or something like that, that we just maintain suppleness of tissues that whole time. But yeah, it's a really great pairing, because if you have tissues that are now atrophic, it's really hard to get as much benefit out of the work you're doing with someone like Ariel. If you can get revascularize or help make those tissues supple and more functional again, then the work you're putting in with someone like Ariel is you're going to get, biggest bang for your buck and a ton of quality of life improvement.
So it sounds very much like both treatments enhance each other, and it's not necessarily, it sounds very much like it's not either hormone treatment or either pelvic floor therapy. It's, taking care of both the musculoskeletal side and the hormonal side, but kind of enhances the entire approach. Is that right?
Yeah. And I think we have a really poor narrative about like this is aging, or like, well, getting old sucks or something like that. But having the hormones on board and then going again to someone like Ariella, that like she's empowering you and showing you the correct way and the means with continuing like your quality of life, or even enhancing your quality of life, to have sort of that knowledge that you can go out in this world and can still squat and lunge and all these things. And also getting alleviation from some of the aches and pains, that new onset of joint pain, and now knowing how to do it safely and correctly is really powerful. One of the huge quality of life factors as we get older is this idea of like independence, like continuing to load my own car, continuing to carry my own groceries, continuing to go up the stairs, all of those things. And that pairing can really set you up for that success.
Yeah. And it's not like it's definitely not like a type of thing where you're like, I'm going to try this approach, and if this doesn't work, then I'll try this approach. And it's like, I'll try physical therapy. If physical therapy doesn't work, maybe I'll try medication. If that doesn't work, I'll go to surgery. It's not like that, because if you just did physical therapy, that doesn't work, and then you go the hormonal route, and then that, like, they need to be together. We have to do both at the same time in order, if you really want to make some improvements, rather than doing one thing at a time, and there's just more time that goes by where you're not getting to a place you need to be, like kind of being able to address everything from like hormonal medication or from like that standpoint, and then kind of how you can incorporate it more into your like physical activity and movement and all of that together is really going to give you a lot of success.
So it sounds like to me, kind of as an outsider, kind of as an insider outsider, it would be really important for someone to then work with a provider who both is considering all of the different options and also work with a provider who's willing to communicate with the other parts of your health team. Is that,
Yeah,
I'm assuming that's
definitely
going to be correct?
Yeah. And I mean, the body doesn't, or systems of the body don't exist in a vacuum, like it's one system. And so having those coincide and working, in tandem, I mean, that's how we function. And our health and our health providers and things like that should also work in tandem for max benefit.
So you guys have mentioned a wide range of things: UTIs, pain with sex, other conditions. What are some other pelvic? It sounds like a very wide ranging, so this might be too broad of a question. But what are some other pelvic floor issues specifically that could be treated with either pelvic floor therapy, hormonal treatment, or both?
Like really anything. I mean, yeah, like incontinence as well. Pain with penetration. If there's tightness in the pelvic floor, that's then causing, hip pain, back pain, things like that, constipation, even things like I don't know, what else am I missing, Erin?
I know, I'm just like, check. Yeah.
It just, it presents itself in so many different ways.
It'd be easier for us, Jesse, to say like what it would not like to improve.
I just think it's helpful to like name it, because often what I find, at least from my side of physical therapy, is I'll tell people, oh, we can help you with so many things, and I'll help them with their shoulder and their knee, and then they might have ankle pain, and they'll be like, oh, I got to go to my doctor, and I'll say, I could have helped you that, and they're like, oh, I didn't know you could help me with my ankle, and I'm like, well, I know that, but people don't often know that, so that's why I think it's helpful to like name actual conditions, and people often are like, oh, that's right, I didn't even realize you could help me with constipation, right? Like that they might not even have connected those two things.
Yeah, no, totally.
Yeah, because I think with pelvic floor physical therapy, I think, in one, most people don't know it exists. Two, I think we have this idea that it's like some woman we should put out to pasture who's peeing herself. And it's like, no, it's like, like we're talking about all these things. Like we don't even think about the backside. I mean, constipation, like this is, like there's things like that. And then how that can, migrate out to hip and lower back pain. To me, like one of the biggest changes I noticed with pelvic floor physical therapy was it changed my gait, how I walked, how I held myself. But yeah, you also think about quality of life. And then with introduction of localized estrogen and suppleness of tissues, that's increased like orgasmic function. I mean, orgasm is a whole thing, but like when you have healthy tissues that are ripe with blood flow, and then you mitigate the pain with penetration, things like that. So like then you're getting into sexual and mental health. So there's a whole host of things. And I also know any woman that has experienced incontinence or male, there does begin to build an anxiety around that. And so when you can treat that and give people like onus and power, take that power back over their bladder and bowel function, I mean, you're addressing mental health then. So the cascading effects is nuts.
Yeah. Also, frequency of urination, things like that too. Like if you're going very, very often, that's another thing that we can help with.
Yeah. And to that point, overactive bladder at nighttime. So the nocturia, helping with that. I mean, think about how much better your life is when you're getting uninterrupted sleep versus waking 4 or 5 times a night to get up and use the restroom. So it does, like I said, the domino effect of the benefits is innumerable.
Yeah, I would almost bet that someone listening to this was like, oh, I don't have those issues. And then one of you just said something and they're like, oh, I guess I have that. And I didn't even
Yeah.
think about it. So
Yeah.
I find that all the time for my side of physical therapy. And I'm sure it's even 10 times the case for what you two do. So let's say someone's, Erin specifically, let's start with you. Let's say someone does start to work with you on hormone treatment. And I'm sure this is all over the map. We talked about all these different conditions. We talked about very individualized treatment plans. How quickly might someone start to see improvement? Like what's the timeline for success look like for someone?
So with I feel like the first things that go by the wayside or are alleviated is the flashing, so hot flashes, especially ones that wake people in sleep, and that can go away in weeks. Also the brain fog, the afternoon slump, and again that unwarranted afternoon fatigue. Those within a couple weeks. I actually had a patient this morning. She forgot to refill her meds and she was off her estrogen for 3 days and started the nighttime waking again, started the hot flashes with interrupted sleep and everything like that. So like it came back pretty quickly and it goes away within, 7-10 days. Um, to the tissue change, that can take longer. So that is one thing to stay the course with, like the localized vaginal estrogen. Stay the course. It's not something you're going to see overnight. It's cumulative effects. But with the oral estrogen or the like through the patches and things like that, the hot flashes, the brain fog, the fatigue, those things start going away in 7 to 10 days very quickly. The progesterone, people don't often know the benefits from it. The people that have new onset of anxiety or difficulty falling asleep because of like maybe anxious rumination, the progesterone within the first, week, they are beginning to fall asleep. They're noticing a calmness, things like that. Those things change very quickly. If we go down the testosterone route, that also can come on pretty quick.
That's great. And then Ariella, how about with you with someone coming in again? I'm sure you treat all sorts of different pelvic floor conditions. How long might it take for someone to both either start seeing results, but then also kind of get to where they want to be long term?
I mean, it's super variable depending on what they're coming in for. Strength takes time to build. So if it's kind of more like we really need to build up strength in that type of way, it might take a little longer. But I find for some people, like if there's like for pain with penetration, let's say, or really kind of changing the muscles in the pelvic floor, you should start to notice a difference pretty quickly. I always find that there's like a hump we have to get over, and getting to that hump, it's like you'll notice. But once we get through that, things change a lot quicker after that. So, I mean, it's so hard to answer. It's so variable. But usually, what I say is like you should be able to notice some improvement, and we're gonna there's lots of different ways to measure improvement. And if it's overall it's taking slower, then I'm very like we're gonna have to try and figure something out. But like sometimes to get to where you need to be might take a while, but you should notice some differences. And even if in ways that maybe you don't think that you have made improvement, you might have made more improvement than you think.
Yeah, one thing I mean we talk about all the time, Ariella, is progress is both not linear and there's also lots of different ways to measure progress. So I think it gets hard to sometimes see progress even when progress is being made, and it also gets hard when progress is kind of up and down. So it can be hard to kind of stay the course, both physical therapy, hormone treatment, like so. Stay the course and work with a provider that is working with you to get over those humps. Usually, is what we say. I don't, Erin, is that kind of what you recommend as well?
Yeah.
This has been great. So, loved our first talk about how to know when hormones might be an issue. I think people got some great tips about how hormone replacement therapy might help them today. Some treatment options, also pelvic floor therapy. So this has been awesome. So if we wanted to leave, like, what's one thing you wish more people knew about, or one takeaway you want people to have from this? Erin, I'll start with you.
That every woman's going to go through this. If you have the privilege to live to this age, you are going to 100% of women are going to go through this. And we're all going to present differently. So I guess my big thing is not chalk it up to this is aging or, just part of life. If something's bothering you, and it doesn't matter how grand the bother is, it's worth investigating. Just this acceptance that like this age has to be worse than this age. it's worth the investigation and it's worth the talk. And also, if you feel like you're not being heard, it's worth finding someone else.
That's great. Ariella, what about you?
That's like almost exactly what I was gonna say. Yeah, like don't settle for just being okay or for being miserable. You have so many options, and yeah, if you find that you have a practitioner or somebody who's not listening to you or just not really presenting you with anything that's helping, like look elsewhere, because you have options, and like we're now in an age, yeah, like where people are talking about it more, so it's really really good, and just yeah, don't settle.
100%.
Well, thank you both for your time. This has been awesome. Erin, Ariella, I really appreciate it.
Yeah.
And looking forward to talking to you guys again.
All right. Thank you.